Well, terrific. We'll silently applaud the speakers. Um, Now we'll move on to the questions and answers. And we received some questions in advance, and Phil Siegel over in Toronto and I will open up the question and answer with a couple of questions. And then David Keller, who's been fielding the very busy chat box, will intervene, and then we'll just pass the ball back and forth. But, you know, one of the questions, I know where to go in England if I'm in the National Health Service to get transperineal biopsies. But, you know, how do we find somebody in Canada or the United States or anywhere else around the world? Now, I did post a link to Matt's company, and there, I think you can run a search there. But you know, so how do you find somebody that's skilled in this? And also, we should mention, as Ferd had mentioned, there's more than one way to do transperineal. So,
Yes, Howard, I might choose to answer this just because, as you know, as I run this company, and we have obviously it probably a day doesn't pass now where we don't get a contact from somebody in the U.S. Or worldwide that's asking where they can get a transperineal biopsy. It's really going to be the patient advocacy groups and the men and the families that care for men to ask for transperineal, because if you don't ask for it, it may not be offered. Even though we've made a tremendous amount of traction, it's still, you know, 5% or less in the US that are done transperineal. Not all transperineal techniques are created equally. I mean, I'm always pleased that people are moving to transperineal, but transperineal, we want to make sure that it's being done safely. And when I say safely, transperineal, again, we mentioned some of the problems with older techniques of transperineal biopsy. We want to maintain the best quality we can when we do. But certainly if you reach out to us as a company, we can direct you. And our site also includes contacts of active users.
We'll see.
Okay, what would you like? Let's see, whoever's, okay.
Me?
Well, let me,
I haven't had a burger in a long time. I think
okay, we're getting interrupted by somebody today.
Else on it, no mayo.
Can you, okay, at any rate, so Rick, your website has a list that people can search, right?
Yeah,
Yes.
so I think Big Celion, who is the distributor of the precision point device in the UK and for most of Europe outside, or points outside America, was approached by me. I mean, I think the history of this is always interesting because the story really is that Matt had this fantastic idea for a device that linked the access needle with the ultrasound probe. And he went to see a very well-known urologist called John Davis, who's at MD Anderson, heads up the prostate cancer service at MD Anderson. And John Davis had visited me previously because he wanted to learn transperineal biopsies, because he was working with the British Journal of Urology, which took articles from the UK and Europe. And as a urologist in America, he knew nothing about transperineal biopsies. And so he inquired of where he should go. And my colleague, Professor Dasgupta, who was the editor, said that he should come and see me. And I was running courses on transperineal biopsies, but this was general anesthetic, grid-based transperineal biopsies. It predated Matt. But John came to see me, and he then spent some time with me, and I then taught him how to do these biopsies. And he took it to MD Anderson. And one of the things is that people say, oh, you can't do transperineal biopsies in the States because you can't do something that can't be done in the office. Now, MD Anderson is a big cancer center. And what John had was a lot of patients who were going for active surveillance, or who had had previous biopsies that were negative, who were then referred for a second opinion. And he was doing transperineal biopsies on all these patients under anesthetic, and he was getting a 70 to 80% cancer detection rate. And so, of course, all these patients were choosing to have their treatment at MD Anderson because their original urologist or service had failed to diagnose their cancer. So actually, the people, you know, the bean counters at MD Anderson were saying to him, you need to do more of these biopsies because you're getting us more work and you're feeding the robot. So one of the things was that Matt, when he had this idea, had visited John Davis, and he was, I think I'm right in saying this, Matt, but Matt was doing his presentation with some videos and stuff like this and talking about his device. And John Davis just closed his laptop in front of him. And I think Matt just thought, oh, well, God, that's gone well. But actually what then John Davis said to him, he said, look, if you really want to know if this device is any good, you need to go and see Rick Popert in London. And then John introduced me to Matt. John and Matt came across to London in, I think, May 2016, and we saw the device, and I used the device under sort of as part of the FDA evaluation of a center that would be evaluating the device under that sort of guidance. And my jaw dropped because suddenly I saw a solution to a problem that I thought was insurmountable. And that is the truth and the story behind this whole development of Trexit, because none of it would have happened if it hadn't been from what Matt Alloway had done. And so he needs to be applauded for that.
Well, let me again ask the practical question. You know, we're hearing from Belgium and from Canada, and I haven't read all of them, but you know, people are wondering who can they get in touch with? You know, Matt, I mean, or Rick, can you?
Well, I think anybody who's seeing a urologist, okay, a urologist is an educated surgeon. And they are educated and they will all understand about the problems. And to be honest, patients should not be ashamed or feel embarrassed to ask their urologist, well, I'd rather have this done transperineally. Where can I go? And the urologist will know. There's not a urologist in the country, in the UK, who can't advise our patients as to where they could go locally. So it is, as Matt says, it is up to the patients to ask for transperineal biopsies, because there's a basic caveat when you're doing consent for a procedure, is that you need to be able to explain to the patient what the procedure is, what the potential complications are, and also, importantly, what the alternative is.
I have another practical question, which is, you know, there's not the capacity today. If everybody in the country who, well, in any of these countries, if everybody that's being diagnosed or is on active surveillance wants to have a transperineal procedure, I don't think that there's enough capacity to handle that. So, you know, like we've had a big pitch here for transperineal. So if somebody needs diagnostics, should they ignore the transrectal in the meantime? You know, is the risk so high that they should avoid it at all costs?
Well,
I mean, Howard, yeah, Richard, you say something because you're in the States, and I'll give my UK view.
Yeah.
Richard, please go first.
First of all, Matt has a directory on perineal on his site perineologic.com.
And the address is posted in the chat room.
Right, and you put in your zip code and you can see which urologists are using his device. So that will help. You can Google transperineal prostate biopsy, and you'll have 5 major centers come right up, university centers. So you can do that. In the United States, the problem is remuneration. Medicare and insurance companies pay a certain amount, and this procedure takes a little longer. The device that Matt has costs a little bit extra, and you know, urologists are very busy, and they're They're a little bit burned out. Actually, they're the most burnt out profession, specialty in the United States for other reasons. So there is there's a barrier towards adoption. The barrier has been somewhat conquered in Australia, where the coding allows the urologists to bill more for the transperineal, and it encourages them to switch because the transrectal's not paid as well. And that's what needs to happen. Then all of a sudden, everybody will want to get trained. To be honest, I have trained some high, what's the word, high volume prostate biopsy people up in UCSF, UCLA, UCI. These are in California, the University of California institutions. And these people have not adopted, and it's remuneration, in my opinion, because they certainly have the bandwidth to do something more interesting and better for the patient, but they do rely on what they get paid. So that's the main inhibitor, in my opinion.
And Richard, we should add that in Australia, the change in their Medicare program, which is a national health program, was brought about by the patients.
Right. So
And-
that's what this group can do, and you're doing as well, to advocate for coding changes. And but
I posted a petition that I wrote, which I brought to the attention of Medicare, as well as the American Urological Association and the Society for Urological Oncology. So sign my petition and write your own letters.
But I just want to finish by saying,
Yeah.
there are enough centers right now, if people are willing to travel, to get the biopsy. The biopsy is not an emergency. Prostate cancer in general takes 4 years to double in size for most of the cancers. So there may be a wait list if you try to go to one center or another, with our, with the low supply of urologists who do it right now in the United States. But if everybody starts going that way, very soon, probably within a few months, the urologists will start adopting this technique so that they don't lose business. It's unfortunately, it's in the United States. It's different than the national health or in other countries where it's a more socialist system.
Well, I'm going to move it over to Phil. I've been hogging the time.
So thanks, Howard. I was going to ask. Well, I have two questions for Dr. Popert. One is really interesting in that, like the UK, Canada is also a national health service. Unfortunately, ours is further complicated by the fact that it's really a provincial. Like the health comes under provincial jurisdiction, so that in effect we have 10 provinces who each have their different views on what's necessary, what's not necessary. How did you get the NHS to approve something like the precision point? Because obviously there's an additional cost as opposed to a freehand approach.
Well, the NHS is quite unique in that a number of procedures have what's called a HRG code, and that HRG code will translate into money paid for a procedure. And a transrectal biopsy under local anaesthetic was paid at about £400, £450. But a transperineal biopsy under general anaesthetic was paid at about £1,200. And that was something that a colleague of mine called Hash Ahmed, who was responsible really for the PROMISE study and the PROTECT study. So two very, very big studies that have really pushed MRI pre-biopsy to the fore. He was able to negotiate for a relatively short period of time this differential tariff for transperineal biopsy, because he was doing transperineal biopsies under general anesthetic or sedation. But what we had when we started with the precision point is that the NHS can only deal with so much. And what code did we apply to the precision point biopsy? It was transperineal biopsy. And so actually we were getting £1,200 per case. And when we were replacing, so if you said to a hospital, if you move your biopsies to the outpatients and you do transperineal biopsies in the outpatients under local anaesthetic, you'll get £1,200 per patient, whereas you were getting £450 per patient for trust biopsy. So it's a little bit like what was happening in what's happened in Australia, where they've created a balance, a differential. Now, your problem in Canada is that there's, I mean, my understanding about Canada, it's all about equipoise and everybody has to have the same opportunity. And I think in the UK through COVID, we've gone to a different way of paying for things. And actually what happens is that you don't get the tariff anymore. You get basically a fixed price for managing your patients, because that's how they've managed COVID. And actually, if you look at the databases and you use those databases to calculate the costs, there is actual evidence that even if you're not using a tariff-based thing, the costs that you save by not having sepsis and replacing with transperineal biopsies are a benefit. And Canada, I think, has got a very, very good, and we have this hospital episode statistics data, and you actually need to go to that, and you need to go and actually see how much infection is occurring as a consequence of trust biopsy, and you calculate the cost of those infections, and then you can actually calculate, well, what would you save if you didn't have those infections? Because realistically, with transperineal biopsies, it's hard. I've not seen anything that suggested that the sepsis rate is more than 0.15%. And if you do transperineal biopsies under general anesthetic, where you're doing the mapping biopsies or saturation biopsies, you have an increased risk of retention of urine at about 10%. And that can cause sepsis. And that skews it a bit against TP biopsy. But TP biopsy under local anesthetic, no retention and virtually minimal sepsis. Therefore, you make your savings, but you have to prove the point.
Not only that, but with what you're doing with the urological nurses, I mean, there has to be a certain amount of I'll call it savings in the fact that you can move a doctor's practice to, perhaps, more severe.
Yeah, or even simply, Jonah can be doing a biopsy list and I can be doing other things whilst that biopsy list is going on, whereas I would have been having to do the whole biopsy list myself, and I'd have been doing that under general anesthetic. So, I mean, the potential for opportunity and savings and transformation of practice is huge.
Phil, if I could interrupt a bit too, because we're kind of coming close to the point that we said we would cut off. If people want to, if our speakers are willing to stick around, maybe I think we talk about lists. We have a lot of questions. So
go through some of the questions, Howard, then.
Yeah. So, okay. So why don't we keep going until they drop or start falling asleep? So Phil, did you have another question or?
No, go ahead, Howard. There's just too many.
I think I got to turn it over to David for a couple of questions because he's got a long list.
Okay, let's start at the beginning of the chat where we had a question from Brian Jarvis, and it may have been answered within the chat box. Brian, you can let us know via chat if it wasn't, but he had a question about antibiotics and their effectiveness, and another person in the chat said that answered Brian's question, and that was, well, if you have the antibiotics, can you still get sepsis from transrectal? And the answer was yes. because the antibiotics, I'm saying this from a layman's standpoint and others can chip in, they had and address a spectrum of bacteria, but it may not cover all the bacteria that the fecal has brought into the system. So,
Could I interrupt, David?
yeah, please go right ahead.
Actually, in 2018, I reviewed 15,000 rectal prostate biopsies. And the title of the paper was Targeted Prophylaxis Does Not Always Work. And what we found was even when we gave the correct antibiotic, that the bacteria that caused the sepsis was sensitive to, often it didn't work. So
Okay.
it must be something about putting the needle through the rectum, that there's just so much bacteria that gets into the bloodstream that it overpowers the antibiotics.
Okay, good. And I'll just volunteer a story in 30 seconds. I was treated with an antibiotic following a prostate-related issue, and I became suicidal. So there is a side effect to some of these antibiotics. I never had been given this particular antibiotic before. This was, oh boy, I won't say the name.
Well,
properly, but I'll
David,
just say-
raise your hand if you need us to talk you off the ledge.
Yes, thank you very much. There was a good question from William Jones that I have and has come up before. William asked, can these biopsies stir up the cancer cells? Can you cause them to activate? Can you cause them to spread around the body?
No.
Could someone please answer that question?
I posed that question actually to one of the world's cancer experts back about 30 years ago, Thomas Stamey, and he, at that time, and I don't think ever since, he said that there's no evidence that biopsies increase the chance of developing spread metastases.
Okay, thank you. Bernard Keeley, you can let us know if we've answered your question. You were telling your story about with sepsis and your experience. There was a question that came up from another person that said, okay, you've had a biopsy and you're okay, you're on active surveillance. Under what conditions do you feel, or that that you feel you have to get another biopsy, whether it be an MRI or a PSA? Maybe somebody could address the threshold metrics that would have to occur before you believe a person would need a follow-up biopsy.
David, I just answer Mr. Keeley's question, because I mean, I think it's worth reflecting upon his story, because obviously Ireland's very close to the UK, and my mother was Irish and born in County Cork in a village called Ballyvorney. So I do feel for Mr. Keeley, but I mean, he had the most terrible story in that he had a biopsy at the age of 40, developed severe sepsis, and ended up having bowel resections and contaminated bone marrow. I mean, I cannot believe how close he must have been to death at the age of 40. And I have a huge amount of empathy for him. And yet, despite all of this, 20 years, 16 years later, he's still worried about his PSA that has gone from 1.8 to 2.9. And he's sensibly, it's been recommended that he have a 3T MRI scan, and that does suggest that he's got a lesion. He doesn't say where the lesion is, but he was planned to have the biopsies done, but because of COVID, it's all been deferred until March 2021. And he has had a biopsy and it's shown a bit of Gleason 3+3 cancer in the left anterior quadrant. And one of the issues is that he's right to be on active surveillance. He's got the benefit of having an MRI scan that showed an abnormality. And if over time that MRI scan shows progression, then there'll be opportunity for more biopsies. And his question is, if I have more biopsies, am I going to stir up, a wasp's nest because I'm I'm irritating the biopsies, and we don't have any evidence of that, Brian. We really don't. Bernard, sorry. And there's no reason to suppose that that's the case. And I don't know where you live in Ireland, but if you let me know, I know quite a lot of the Irish urologists anyway, but most of them are very sensible urologists, and they would offer you the opportunities for further biopsies if necessary. And that should be decided on whether the MRI scan shows a significant change in the lesion. And I think if you've got a PIRAD 4 lesion, so if you can see a lesion on the MRI scan, in my view, that really calls 3+4 or 4+3. It's intermediate risk cancer. It's rare to get 3+3 in a lesion that you can see. So my worry for you is, could the biopsy have just skirted the edge? It's picked up the abnormality, but there might be something more going on. So in your situation, I don't know when you had your MRI scan, but I'd probably do a repeat at 6 months, not 1 year, just because I want to see if that is changing. And I know urologists will differ on their recommendations, but you can use your MRI and repeat biopsies sensibly in order to evaluate an individual. And often it's the PSA in relation to the volume of the prostate, what we call the PSA density, an MRI lesion that will determine for me whether I recommend that people have an earlier repeat biopsy. But don't be concerned about a repeat biopsy affecting your risk.
Okay, thank you very much. That was a great answer, Rick. And I just want to put an asterisk next to your PIRADS 4 statement. I had a PIRADS 4 2.7 centimeter lesion, and the pathology report came back after 57 cores were taken and a saturation transperineal biopsy where I suffered greatly from AUR, horrific AUR, acute urinary retention, twice ambulance to the emergency room to be catheterized.
Well, David, was that the older technique?
Yeah, that sounds like.
It wasn't precision point. In fact, he didn't even use an MRI guided. He just used the ultrasound under general anesthesia. And so, you know, so he could have done, he has used fusion in his clinic, but not at the hospital. Hospital didn't have the equipment. So he just did the, I guess what you would call ultrasound guided without the benefit of an MRI fusion ultrasound guided. And my part of the point there was that the hospital pathology department found 3+4, which supports your statement that if you got a PIRADS 4, you probably have at least a Gleason 7, 3+4, maybe more. But when my tissues were sent to the Cleveland Clinic, urology department, Eric Klein's group, 3+3 only. In fact, I did an Excel spreadsheet on all this data from 57 cores. And in fact, one of the 3+4 sites found by the hospital pathology department, they found nothing, not even a 3+3 at the Cleveland Clinic, which I thought was kind of strange. So I just wanted to pass on that anecdotal experience, Doctor. And go ahead. Anybody want to say anything about that?
If there isn't, I'll pose the next question. Okay, so nobody's leaping to.
Well,
I have more questions. I'm going through the questions in the chat box. I'm sorry.
We're going to switch it around, David.
Go ahead, please do.
Real quick. Oops.
Go ahead, Richard.
So it is controversial how you do active surveillance, and it's controversial what is considered low risk and intermediate risk, and that's where you might find opinions depending on your centers. For instance, the AUA guidelines only mention it in terms of guidance that if a patient has low risk disease, active surveillance should be recommended. And all they say really is that you should repeat a biopsy within 2 years, and then following that do surveillance biopsies. They don't really tell you when to lower the axe and change to treatment instead of active surveillance. It's not really worked out, and there are many different papers with different opinions, and you're just going to get a different answer, but not radically different answers from
we
a urologist.
Yeah, we should mention that the American Urological Association is in the midst of rewriting or revising their guidelines. I've been in touch with the director of research for the AUA. Actually, she was supposed to come today, but our doors closed prematurely. So the AUA, the American Urological Association, is considering doing something more. And at their September meeting in Las Vegas, they're going to have what they call a crossfire debate about this subject. So, it's rising to the top as a concern. But again, patients need to talk to their doctors about this, write a letter to the AUA. I posted a petition that I wrote, and about 300 people have signed it, including leading urologists from the United States and Europe. But let me ask another logistical kind of question, and trying to get urologists to go along with this. I was in touch, let's say, with a relative of mine who's a urologist, a young one. And I said, I have this petition, why don't you sign it? She said, oh, well, this isn't a problem in my practice. I haven't done a head-to-head comparison, but I only have a 0.5% infection rate. And she was happy with that. And then I want to mention too, I was speaking with an advocate who has more advanced prostate cancer than most of us. And he just kind of ridiculed the idea that transrectal biopsies are an issue at all. He said, yeah, you might push the needle a little on it, but we got COVID, we have world peace, we have all these global issues. So, he was just kind of making this like a speck, just kind of, playing it down. So I wonder, if advocates take this kind of position, young urologists take this kind of position. I mean, how do you're saying that we, the patients, can surmount this, but, what about you doctors out there? What are you doing, and what can you do? We're not delegates to the Urological Association.
Well,
So,
while they contemplate that, Howard, we have a statement from a question from Eric Briers. How
wait a
about the
minute,
learning?
let them answer, and then you can ask.
The only thing I would say is, of course, you're going to get inertia. The non-spoken problem is it's difficult to learn a new technique. Not that difficult, but it's just difficult when you're very busy, and they're not getting paid for that extra effort and for the little bit of increased cost. So it's just easier to put your head in the sand. But it won't be that easy if everybody demands it, like has happened in Norway or in Australia. So that's my answer to them. Just go forward, and you can pose the question. If you're in the hot seat, if you're taking that flight from LAX to JFK, which plane do you want to be on? And that's my answer.
So David, why don't you go with Eric now?
Yeah, but thank you, Howard. That was great. I really appreciate that answer. I fell into one of those small percentiles of surgical negative side effects. And so that 0.5% is fine for the 99.5, but if you're in one of those 0.5%, you're not happy. You've had a bad experience. I'll just leave it at that. Now, these people that talk about, only 3% of the people, suffer avascular necrosis when they have this ankle operation. Well, I was one of the 3%. Now they want to amputate my ankle. So, yeah, just because the number is small doesn't mean, and we've heard the numbers, if you build that over the whole population, that is a lot of people. So this is serious, and it's not to be made into a speck or small of.
But
Eric
the
asked a
individual
question.
to whom it happens, it's 100% complication.
Yeah,
It's
there you go.
0.5%.
That's exactly right. It was
And
100%
that's
for
why,
me.
you know, if you can have a risk that is definable, then it has to be explained to you, because if you suffer that complication, it's a significant complication, and in you, it's 100% complication. So whatever they say, however they try to dismiss it, it's a complication. And would they take that risk themselves? That's the other question you have to ask.
The brilliant question. Another question, since you brought that up, how easy is it for a patient to ask a doctor, if you were going to have this procedure, who would you go to?
It's a great question, because most surgeons would say, well, of course it's me, because I think I'm the best. But there are, you know, there are people who do things better than I do, and I would recommend that a patient went to see them. And, you know, I think it is about the relationship that you have with the doctor. And always, you know, you would want the doctor to say, well, this is how I would treat you if you were my brother. This is how I would treat you if you were my father. And, you know, if they don't say that kind of thing to you, if they don't give you that feeling that they are, you know, involved with your care and your problem as much as you are, then go to another doctor.
Perfect. Great answer. And that leads up to this question from Eric. How about the learning curve for transperineal biopsies? How many have to be done before it works fine?
Well, I could tell you my experience. Rick could tell you his too, and also Richard. Um, I find that most urologists, after about 3 to 4 cases, it sort of clicks on how the hand needs to move. And then certainly by the time they've done about 20 cases, I think their speed and their competency is very good. But you know, as important as it is to go through the perineum, it's equally more important, actually, in some ways, that we know where to position the needle. So it's really just not this idea of poking the perineum. I mean, David, the biopsy you went through, that standard, you know, sort of overly saturated TP grid-based approach is a horror. We know we don't have to stick the prostate transperineal 56 times to find the cancer. In fact, the larger the prostate, in some cases, less cores are needed. If you understand the zonal anatomy of the prostate and where the needles need to land, that's the key. That's why training is so important. That's why our company spends so much money training people. We just don't we won't sell a device to any urologist unless they've been personally trained. They either have to come to our training facility or we have to go to their training facility. We keep track of them. We're is more interested in their results than they are buying our product. So we encourage them to keep a database. We want their dashboard of cancer detection to be hovering around 70%. If there's ever a problem, if we ever hear about an infection and they reach out to us, we investigate to see what may have gone awry, technically speaking. But really the move we've made now is to abandon antibiotics completely. I mean, you can't do a transrectal biopsy without antibiotics. You can clearly do transperineal biopsies in these new methods without any antibiotic whatsoever, because I'm as much of a antibiotic urologist as anything. I think, why do I want to put any of that poison in any patient's body if it can be avoided? So it's really the training and the technical aspects. But I would say about 4 to 5 cases, it clicks. By 20, they should be in the groove.
Okay, thank you for that answer. And I had a follow-up question for you, Matt, from a previous discussion or rehearsal, and you've addressed it, but maybe I was trying to figure out, how do you get you know, all these samples through 2 punctures? And it sounds like I was thinking maybe you had to curve the needle like a baseball pitcher throws a curveball, but it sounds like the needle can go straight. You just move the prostate up and down with your with the rectal probe. Is that what you're doing? Is that how you line up the proper sector of the prostate with the needle?
Yeah, the way we engineered this is not, I mean, the fact that the access trocar is coupled to the ultrasound probe, so it stays in unison, that's a simple property, but the secret sauce is really how we exploit the perineal scruff. So, you know, you grab the scruff on the back of your dog's neck, you can flop it in every direction. Once we anchor into either the right or the left access point, we're able to, in unison with the probe, able to shift the entire anatomy and the prostate to realign our access point to a completely separate trajectory. So and we're doing this now where we're tracking every core, and you can see that each core is actually not fanning from a fulcrum like my old coaxial needle method, but rather we're shifting our trajectory to a new runway. So I imagine that every biopsy is like a new runway on the prostate anatomy in the relevant zones. And I think that we try to teach our users to look at the patient's anatomy and then slightly customize where they take the cores based on those zones, the peripheral zone thickness, the region of interest, the anterior prostate. So I don't think it's the biopsy cores are necessarily a one size fits all. Of course, to standardize these approaches, everybody wants, like transrectal, it's 12 cores. That's been determined to be most accurate. But to say that 12 cores is equivalent for transperineal is not necessarily the truth. We believe it's probably somewhere between 16 and 20, which sounds like a lot, but you have to remember that in our experience, increasing the number of cores does not increase pain scores. It doesn't increase patient morbidity with our method. So as long as there's zero harm to the patient, why would we not want to have the very best experience with each biopsy? It's not about saying, well, geez, I want to get this done in 5 minutes. I don't want to spend 8 minutes on this biopsy. Each patient deserves to have that sort of bespoke biopsy experience.
Thank you. Thank you. I really appreciate that answer.
Yeah,
Brian,
Matt.
Go ahead.
Yeah, Matt, let me ask a US specific question. We've had some people asking, does Medicare and private insurance cover your technique?
There are codes for the biopsy, yes. But the problem with the American coding system is that it's a bit antiquated. In fact, if you look at the coding manual, the biopsy code is biopsy any method. Well, that code was actually established in the early 80s when we stuck Vin Silverman needles through the patient's anatomy. That's when we stuck a finger in the rear and ran a needle alongside. So the coding system is very, very outdated. There is a transperineal code that in certain settings qualifies with our method. So you can still use the standard transrectal codes. You can use the transperineal code if appropriate in the right setting. We're trying to encourage the AUA to support a reevaluation of these codes so that urologists will be willing to learn. I mean, that's been one of the issues is, well, I got to buy some new equipment. Perhaps I have to go through some sort of formal training. The workflow is going to be a little different for my practice initially. The cost of the procedure is no different really other than the cost of the device, but we feel we tried to keep our price very, very low compared to most medical devices. So we could be, competitive to get into countries. In fact, you can see with Rick's work in the UK, that's a socialized medicine system it sees the value proposition. Unfortunately, in the US, it's not all about the value proposition when they look at the whole global picture. It's a little challenging, but I think we're getting there slowly but surely, especially with the work that these organizations, ASPI, Howard, your columns, these things make a tremendous amount of difference. It creates enough noise and dialogue.
Phil, do you have any more questions?
I don't at this moment, Howard, or else we'll be here till dinner.
Well, I'd say let's go for about maybe another 10 minutes. David, do you have some questions?
Well, go ahead.
there is a very important question, which is regarding the pain of transperineal biopsies, which I think people are obviously, they know about transrectal biopsies. And one of the things I think there's Brian Jarvis from Ohio said that he had a lot more discomfort from a transperineal insertion of a perirectal spacer than he was experiencing with a transrectal biopsy. And what people don't always understand is that when you do a transrectal biopsy, you put the probe into the back passage, the needle that puts the anesthetic goes through the rectal wall to the back end of the prostate gland to inject the local anesthetic around the base of the prostate gland into what's called the neurovascular bundles, which provides the sort of the pain fibers. But the rectal wall has no sensation. If you imagine somebody pushing a needle through your anal margin, you know that would be painful. But you only have to go beyond the anal margin inside the rectum, and the rectal wall doesn't have any sensation. So if your needle goes through the rectal wall, people don't feel much pain. They feel the discomfort of the probe, but not the pain of the injection. And that is different with the transperineal approach, because the needle has to go through the skin, which is Howard talks about is the taint, you know, it taint the anus and it taint the penis. It's the bit in between, and that's the skin. So the skin is painful because you're putting an injection, like any injection would be painful. And then you have to put a deeper injection around the prostate gland. Now, I suspect that Brian was probably having a procedure done under local anesthetic by a urologist or an oncologist who was using what's called a stepping unit, which is the standard technique for doing a transperineal biopsy or doing prostate brachytherapy, where you put this great big thing inside the rectal wall, inside the rectum. And it's possible that the doctor was trying to put different injections inside through the skin. Now, the way that Matt taught me was all about making sure that you got the skin infiltration correct. And when we do the deeper injection around the prostate gland, I do it very quickly. And I put the injection in on one side, and I say to the patient, and you saw the guy who had the injection in the video I did. Now, he winced when the needle went in, but that wince lasted 5 seconds, if that. And then by the time I'd completed the injection and done the injection on the other side, I do the injection. It takes about 10 to 15 seconds. And then I take the probe out. And then I ask the patient, do you have any pain now? And I've never had a patient say they have pain. And what happens is you take the probe out and then you wait for the anesthetic to work. And I suspect that Brian's experience was probably that the doctor doing it hadn't learned some of these subtleties of doing the anesthetic in as painless a way as possible, and therefore he had an uncomfortable experience. Now, he could go around and tell everybody, oh, I wouldn't have it done that way, it's very, very painful. And yet I've got other patients who are very, very comfortable because they understand what's happening as it's being done. But you do the injection quickly, and then you get out of dodge because you don't want to get into trouble, and then you'll come back later when everything's settled down, and you can get back into dodge, and you can do the biopsies or the spacer with comfort. So the technique is critical.
Yeah, I would agree, if I could say. I have a little bit of a different view of that. And I train people, and so does Rick and Matt. My impression from a particular, reinforced by a particular paper I read, Rick, I think it came from your hospital actually, but it might not be. It might be a different hospital, where they actually measured the pain scores on placing the rectal probe, the injection initially, and the injection of the pelvic floor muscle that covers the prostate. And they found that the injection of the pelvic floor muscle was the most painful area. And so I've always, when I train people, I say, go very slow. Once you get in fast, but once you get into that muscle, inject ahead of yourself so that before the needle gets there, the anesthesia gets there. And so inject that, and then everything, and it's pretty easy peasy once you get that all taken care of.
Can I give a reflection and response to that? So when you came and visited me in London, that was very much the sort of technique that we were doing, which is where you're putting the needle just off the midline up through the perineal body. Now, the perineal body is the thickest part of the pelvic floor. It's where all the muscles come around the urethra, the apex of the prostate gland. So I've gone away from that completely. And what I do is I rotate to the lateral side of the prostate gland, and I drive my needle very quickly alongside the prostate through what are called the levator muscles, the levator muscles, which are the muscles that I just sweep away when I'm doing robotic prostatectomy, and they just fall away. And the tissues are very, very much thinner. And you can inject into that space. You can drive the needle along very quickly, inject very quickly, 2 passes on one side, 2 passes on the other side, take the probe out, and then wait. And actually, you then find that that central part of the pelvic floor, the bit that you refer to, is often anesthetized after 6 minutes.
I see.
So I will go and I will do the injection, then I will go away and do something useful. I will go away and make a cup of tea. I will go and make a phone call. I will leave the patient talking to the nurses about anything to do except prostate biopsies, or I might even go and look at the MRI scan and decide where I want to take the biopsies from. But it is amazing how effective that technique is.
Thank you. So we're obviously still learning from each other.
Yeah, but that's the way it should be.
Well,
Yeah.
tell you what, we're half hour longer, and we probably haven't answered all the questions. I want to thank all of the speakers and all the members of the audience for all of their questions. We are going to address this again on August the 25th, when we're going to have Agnes from Norway, Dr. Johansson from Norway, and maybe a few surprise guests. I don't know yet. But at any rate, I appreciate everybody turning out. But I think we probably should go. If Jeff, are you still here? Maybe he quit on us. He was going to hold out a hat to raise money. I'm not going to do that.
I'll do it. We're always interested in funds to support these kind of programs. So folks, if you're going to give a gift in 2021, think about this particular group. And you can go to our website, aspatients.org. Thank you.
So I think that's about it. The program team, if you guys want to hang around a little afterwards, in other words, I guess we're saying goodbye and thanks.
I'll just say, if somebody wants a question answered, because there's a couple we didn't get to, just put your email into the chat group and I will personally answer those questions or get the answers to them.
And I saw some silent applause. We appreciate that. Yeah. So, at any rate, I think that's it, gentlemen and ladies.